on the imaging symposium, which all of us are waiting for Dr. Gary Mintz and Dr. Akiko. They have already joined. Thank you very much for joining, sir. It's a pleasure to have you in this year's meeting. And any imaging session, people always look towards you. And we also have our Indian expert, Dr. Kirti Punamya, and Ramesh Dagupati. Again, it's difficult for us to tell whether he's in US or India. Always there to help us too, and he will also share his experience with ACS. And with these few comments, I request Dr. Gary Mintz to take over and conduct this session. I think Dr. Akiko Mehra also joined. Other panelists, if they're there, please join. Ajit Mehta, Balaji, Pradeep Deshmukh, and others. Over to you, Dr. Gary.
So thank you very much for asking us to put on these two imaging sessions. There's a 2-hour IVUS session, then a break for live cases, and then a 2-hour OCT imaging session. My co-chairs are obviously Akiko Mehara and Sanjov Kalra. So I'm going to start with my talk. So this is a talk that I put together and constantly update to show how important intravascular imaging has been in the development of PCI. Everybody knows that Andreas Grunzig invented PCI, but not so many people recognize that it was Jeff Hartzler that is responsible for modern PCI, including multi-vessel, CTO, primary PCI, evidence-based medicine, formalized PCI fellowships, and so on. He really is the father of the PCI that we practice today. But they only had balloon angioplasty, and it became obvious that balloon angioplasty had severe limitations, and that ushered in an era that we called the new device angioplasty era that included coronary atherectomy, laser angioplasty, and intravascular imaging. Intravascular imaging was invented by Paul Yock. This is his original poster presented at the AHA in 1988. And his conclusion was that catheter ultrasound may be useful in directing mechanical atherectomy, laser ablation, or other forms of catheter-based therapy, and it may allow maximum debulking of atheroma while minimizing the risk of vessel perforation. Using intravascular ultrasound, we understood the limitations of angiography. This is a paper that I wrote many years ago in 1995, which showed that angiography is extraordinarily limited in assessing the presence of calcification. We also looked at lesion eccentricity, and it became obvious that irrespective of what a lesion looked like angiographically, half were eccentric and half were concentric. And if you looked at a bifurcation lesion, the plaque is almost always opposite the flow divider. This is the circumflex. This is the plaque in the ostium of the LAD. And then we became obvious that most of the atherosclerosis is hidden and is angiographically silent. In fact, 3/4 of the atherosclerosis in the coronary arteries are in segments of the coronary arteries that look normal by angiography. And this substantiated in vivo what Seymour Glagov showed in the pathology laboratory, that is, Glagovian remodeling or positive remodeling occurs to maintain lumen dimensions and hide most of the atherosclerosis. Well, we also used intravascular ultrasound to assess the successes and failures of these devices and the mechanisms of restenosis in a way not possible with angiography. And prior to the seminal serial IVUS studies, it was believed that intimal hyperplasia was the cause of restenosis in non-stented lesions, and that in-stent restenosis was caused by chronic stent recoil. But we saw cases like this. This is an LAD after directional coronary atherectomy. Here is a diseased septal perforator, no residual plaque of any significance. The patient comes back with restenosis, presenting as a total occlusion, and the vessel has totally collapsed or shrunk or been constricted. And again, here is the same diseased septal perforator. And Jeff Isner wrote an editorial, "Honey, I think I shrunk the artery." Well, nobody was quite sure what this meant. So this led to my first trip to Japan in early 1990s to initiate the SURE study, because Nobuyoshi and his colleagues were doing serial angiography in patients after angioplasty and atherectomy. So we did a study where IVUS was performed pre-intervention, post-intervention at 24 hours to eliminate recoil at 1 month and at 6 months in a relatively small number of lesions, 26 treated with atherectomy and 35 with balloon angioplasty. And this is what we saw. And let's just look at the example. Pre-intervention to post-intervention, no change at 24 hours. The vessel grew at 1 month and then shrunk at 6 months. And that's exactly what we saw in the overall data set. And in fact, there was very little increase in plaque from post-intervention to 6 months. We'll come back to this at the end of my talk, but keep in mind that restenosis in non-stented lesions is the result of shrinkage of the artery or perivascular scar formation and constriction. Well, as part of the new device angioplasty era, Julio Palmaz invented the bare metal stent, and in-stent restenosis was thought to be the result of chronic stent recoil. The other thing you should understand is that the early experience with the Palmaz shot stent was terrible. Most of you don't remember it, but these stents would thrombose acutely. We would have the patients on anticoagulation to prevent stent thrombosis. Even if they had a GI bleed, we were fearful of stopping the anticoagulation because of the fear of stent thrombosis. It was a horrible, horrible experience. Until Colombo and his colleagues using IVUS showed that suboptimal stent deployment was common and identified the proper technique for optimal stent implantation, using high-pressure adjunctive balloon inflation in particular. And finally, the FDA approved the bare metal stent in the US. And we used IVUS to understand the predictors of bare metal stent early thrombosis and restenosis, the number 1 being under expansion, and the number 2 being edge problems or geographic miss. And we also used serial IVUS to understand why stents restenose. As I mentioned, Julio Palmaz thought that in-stent restenosis was because his stents were not strong enough and they collapsed, but the serial IVUS studies showed that chronic stent recoil was rare and that most in-stent restenosis was the result of intimal hyperplasia. We also identified mechanical causes of in-stent restenosis. Chronic stent under expansion was common. The stents were just never properly implanted. And we saw cases such as this, where in-stent restenosis in the osteoproximal right coronary was because the stent was crushed to the side of the vessel wall. During the procedure, they lost wire position, and in rewiring the stent and then post-dilating it, the stent was crushed against the vessel wall. Conversely, edge restenosis was the result of negative remodeling potentiated by a large residual plaque burden, just like restenosis in non-stented PCI procedures. Well, new bare metal stent designs did little to reduce in-stent restenosis. Some patients had recalcitrant and recurrent in-stent restenosis, and clinical and IVUS studies showed that bare metal stent restenosis did not respond to balloon angioplasty, any kind of atherectomy or laser angioplasty, or restenting, irrespective of the acute result. And that led to the short-lived routine brachytherapy era, in which bare metal stent implantation was followed by anticipated intracoronary radiation to treat inevitable cases of in-stent restenosis. But it was the IVUS findings that helped to end routine brachytherapy by identifying aggressive edge restenosis, black holes in the tissue representing immature cells in the neointima, late-acquired stent malapposition, non-healing of edge dissections, and aggressive late catch-up in neointimal formation. The obvious solution, of course, was a stent to prevent chronic negative remodeling that is present in non-stented lesions, plus a drug to prevent intimal hyperplasia that was common in bare metal stented lesions. And obviously we had the first generation DES, Taxus and Cypher, but we used intravascular ultrasound to identify drugs that would work. In small numbers of patients, you can do a serial IVUS study and see the percent neointimal hyperplasia volume and see which stents will and will not work, because the standard metric in bare metal stents is 30% NIH volume. Randomized clinical trials led to the FDA approval of DES in the United States, and as well as for treating bare metal stent restenosis, which finally ended routine brachytherapy. And we looked at the predictors of early stent thrombosis and restenosis with drug-eluting stents, and they turned out to be identical to bare metal stents: under expansion and geographic miss. But then came the ESC firestorm in 2006. It was suggested that drug-eluting stents increase patient mortality, not cardiac mortality, but all-cause mortality. And Forbes magazine had a article calling drug-eluting stents a million ticking time bombs, and the use of DES in the US plummeted to the mid 60%. Well, about that time, Gary Tierney applied optical imaging to the coronary arteries and invented optical coherence tomography. These are his early images. They're obviously very primitive. And we used OCT to try to see if there were additional predictors of DES failure, but the OCT findings merely substantiated the IVUS findings, number one being stent under expansion, and number two being edge problems or geographic miss. But OCT was able to assess stent thrombosis and in-stent restenosis in a way not possible even using IVUS, and we used OCT primarily to study tissue characteristics after in-stent restenosis. And here, for example, you see neointimal rupture, thrombus formation, and so on. But it was actually angioscopy that identified neoatherosclerosis as an important cause of restenosis in first-generation DES. And once neoatherosclerosis develops, these are OCT studies, stent failure is predictable. You see an example on the right: no neoatherosclerosis, and at long-term follow-up, once neoatherosclerosis is recognized, stent failure is almost inevitable. We also use OCT to look at causes of very late stent thrombosis and recognize the importance of neoatherosclerosis in this setting as well. And of course, stent optimization using intravascular imaging led to better patient outcomes, as was shown in these many randomized trial publications, meta-analyses, and registries, and I will just highlight one or two. This is the National Registry in the UK of left main stenting, showing that intravascular ultrasound guided left main stent implantation has a nationwide 34% reduction in cardiac mortality. And in the Korean online AMI registry, intravascular imaging, whether IVUS or OCT, reduced patient and device-oriented events because of reduction in all-cause and cardiac mortality. Of course, we have to mention the bioresorbable scaffold era, which started around the year 2000, now 20 years ago. Imaging was used to understand the absorption characteristics of the bioresorbable scaffold, and also to understand the restoration of normal remodeling, and in fact, even potentially plaque regression. But as you all know, there were a number of studies showing that scaffolds had a higher event rate compared to modern metallic everolimus-eluting stents. And in response to the FDA's concern, Abbott stopped selling Absorb. So what were the IVUS or OCT findings or predictors of early scaffold thrombosis or restenosis? There weren't any. Why? Because the use of imaging was not only not recommended, but was actively discouraged. And the systematic serial imaging studies were limited to a few patients in cohort A and cohort B, and there were no acute implantation studies similar to the early reports of Colombo and his colleagues. Only recently have we begun to understand mechanism of scaffold restenosis and thrombosis, and here you see the INVEST registry showing using OCT scaffold discontinuity, neoatherosclerosis, and so on. And as I mentioned, scaffolds are not immune to neoatherosclerosis. That was one of the hopes, as shown in this paper from 2018 from Japan. So let me just share with you quickly one case. This is pre-intervention, post-intervention, 6 months and 15 months after a bioresorbable scaffold. Notice how the vessel has shrunk from post-intervention to 6 months to 15 months. And restenosis was mostly caused by constriction of the vessel, almost exactly as was predicted by the serial ultrasound restenosis study more than 20 years previously. A few quick words about primary PCI. Let me just skip ahead. So intravascular imaging has looked at lesions associated with primary PCI, and it was recognized that if the fibrous cap was intact, the patients did better at long-term follow-up, and this led to the concept of erosions that could be treated medically, as was shown in the erosion study from Harbin, China. But also intravascular imaging was used to recognize the presence of SCAD and calcified nodule. And in fact, the intravascular imaging studies were the earliest studies to recognize these phenomena. Jim Miller, of course, started the vulnerable plaque era and was instrumental in developing near-infrared spectroscopy. And now we have the evolution from Prospect 1 to Prospect 2 and Prospect Absorb. And a Prospect Absorb showed that it may be possible, and it may even be scientifically valid, to treat vulnerable plaques using some kind of mechanical device. The last thing I want to quickly mention is education. Everybody thinks that Andreas Grunzig invented the live demonstration course, but that is not correct. These are two paintings by the American artist Thomas Eakins in the 1800s, and it showed that all procedures, surgical procedures in this case, were taught in live demonstrations. The Gross Clinic painting on the left, the Agnew Clinic painting on the right. You see the students in the audience, but these were also used to identify progress in technique. Notice that here in 1875, Professor Gross was operating in street clothes. In 1889, Professor Agnew and his colleagues are now using gloves and surgical gowns. And Thomas Eakins even painted himself into these paintings as an observer. Well, the first TCT in 1988 predated intravascular imaging. This is the first live demonstration course that I was able to identify. And what I just want to show you is what the early images look like. So this is what we had to work with in the early days of intravascular imaging. Nobody could have imagined that this was the nidus for what we do today. And in 2018, second to the last live TCT in the coronary theater, you can see that on the left, OCT angiography co-registration guided stent implantation, and on the right, zero contrast PCI. So if I can quickly conclude, intravascular imaging has been fundamental to the evolution of PCI and the understanding of coronary disease and its treatment from a time in the past when the images were primitive and PCI techniques were limited to balloon angioplasty, to the present, when images approximate in vivo histology and PCI techniques are science fiction-like in their sophistication. Thank you for your attention.
Thank you. Thank you, Gary. There cannot be any better person to take all of us through this evolution of imaging. That's why we selected. And even in Indian mythology and philosophy, Charaka Samhita also did some live demonstrations. You quote there. But in India also there is some history of doing some live demonstration through surgery in Charaka and Samhita. It is long time thing. But you showed early imaging orientation pictures, how the imaging came down and how it improved. All that. We have little time left. Kirti, you want to say comments? Please.
I think this is a tremendous journey that Dr. Mintz has shown. I mean, it's right from the early days to now. I think it was just detailed and exotic. Thank you so much, Dr. Mintz, for that journey.
Yeah, if anybody ever goes to Philadelphia, those two paintings hang in a single room in the Philadelphia Museum of Art. And the Gross Clinic is considered to be the finest work of art ever by any American artist. It is a magnificent painting.
Thank you.